Good morning. My name is David Wordley, and I'm very pleased to welcome you to Zenith Global Health Summit. Just a little brief piece of housekeeping. Could I ask everyone, if you have any questions, please use the Q&A to ask those questions. And just to welcome you all here and to ask our moderator for this session, Dr. Rebecca Pope, please introduce yourself, and then you can ask all the panelists to introduce each other in turn. Thank you.
Thanks, David, and hello to wherever you are in the world. Thank you for giving us some of your Saturday. My name is Rebecca Pope. My pronouns are she and her, and I'm the UK Digital and Data Science Innovation Lead at Roche. My background is a PhD in artificial intelligence applied to neuroimaging and different brain conditions, did some postdocs, then went to an NGO, did lots of thinking, not much necessarily doing, then joined IBM as this thing called a data scientist, where we got trained up in coding, and eventually led the Watson European Health part of that organization. Then moved over to KPMG, where I grew their public sector business in artificial intelligence. And now what do I do? Now I have the privilege of working with an ecosystem of partners, including healthcare systems like the NHS, regulators, and others like technology, and some of the folks actually on this call, to say, how do we start to bring innovation into patient pathways? How do we help patients and citizens in their journey to manage their health better, to identify maybe poor health earlier, to optimize patient pathways and hopefully improve outcomes? And it is my joy today to hand you over in a moment just to our panel. Just a bit of housekeeping, if that's okay. Please feel free to use the Q&A in the side. I will keep my eye on that as questions come in. You will have an opportunity to bring up those questions. All fire alarms are unplanned. So if you hear one, please leave your own home or wherever you are sitting. And without further ado, I will hand you over to Prokar. Over to you.
Thank you, Rebecca. Good morning, everyone. Great pleasure to see you on this amazing webinar. My name is Prokar Dasgupta. I am the King's Health Partners Professor of Surgery. So I look after surgery across 5 organizations south of the River Thames. King's College London is the university, and 4 major teaching hospitals, Guy's, St. Thomas's, King's College Hospital at Denmark Hill, and South London and Maudsley, which is our mental health trust, incorporating the Institute of Psychiatry. So a real pleasure to be here. And I wanted to personally thank Mary Akangbe for bringing us all together at this Zenith Global Health Summit. Mary, you're doing an amazing job, not just keeping things modern, but also keeping it topical and diverse. And I think this theme of today is very, very important for the future of how we practice medicine and surgery. So it's a real pleasure to be on this call, and I look forward to interacting with the audience and you all. Thank you so much.
Thank you. And may I hand over to Nadine?
Thank you very much. And thank you so much for the invitation. It's always great to be on a panel with so many great speakers. My name is Dr. Nadine Hachach-Haram. I'm a consultant plastic surgeon. I have the pleasure of working at the same trust that Professor Prokar Dasgupta does as well. My clinical practice is mostly breast and pelvic cancer reconstruction, but I wear a few hats, and hopefully throughout the discussion, the benefits of that will come to light. I'm a head of innovation and clinical innovation and strategic industry partnerships at Guy's and St. Thomas's. We really look at how we can bring the private and public sector together to try and influence how we reimagine healthcare for the future. I co-manage KHP Ventures, which is a venture arm for our organization between KCL, KCH, and GSTT, where we're really helping to pump, prime, and invest and catalyze new frontline innovation. And I'm an entrepreneur and an operator myself. So I'm a founder and CEO of a fairly fast-growing company called Proximie. And we'll talk a bit more about Proximie, but it was really designed from a frustration firsthand that I had as a surgeon. How do we try and bridge the gap between opacity of the operating room, the lack of standardization in surgical care, the variability in outcome and results and access both in the UK and all around the world. And so Proximie is a software platform that enables you to virtually scrub in and operate and collaborate in operating rooms around the world, and helps you aggregate and collect information knowledge from that operating room, which hopefully can influence future cases as well. It's great to be here. I'll talk more about it, but I'll hand back to you, Rebecca.
Thank you, Nadine. And wow, what truly incredible hats to be wearing. So thank you for sharing all of those with us. It's wonderful, and it's great to have you on the panel. Now I'd like to hand over to Oliver. Oliver, would you mind telling us about yourself?
Sure. Hi. So my name is Mr. Oliver Brunckhorst. I'm a urology PhD fellow at King's College London, and also urology trainee in South London. So a lot of my work is focused around looking at mental health, and particularly the relationship between mind and body and prostate cancer. And a lot of what we're trying to do is kind of integrating or trying to predict who's doing better and who's doing worse after being diagnosed with prostate cancer. So not just mental health, but also other issues like fear of cancer recurrence and things like that. So it'll be a kind of pleasure to speak a little bit about that later on, and how we can integrate healthcare, hopefully in the future, within that.
Thank you. And Modar, over to you, please.
Thank you very much, Rebecca. Hi, everyone. I resonate the kind of same feelings. Very happy to be here. Thank you for allowing me to be part of the panel and to be able to share this space with some of the great minds that we have on our panel. I'm actually from industry, so I work with Medtronics, which is the world's largest medical device manufacturer, and I'm here as part of a support mechanism. So we develop a lot of the technologies to be able to drive these positive patient outcomes with new innovative technologies. And one of those technologies that I'm responsible for in the UK and Ireland is surgical robotics.
Thank you. And actually, I'm a type 1 diabetic. I have your CGM and your insulin pump. So thank you very much for that, and to your colleagues for making my quality of life so much better. And last but not least, handing over to Alejandro.
Good morning, everyone. Thank you, Rebecca. It's a pleasure to be with all you today, this morning, and thank you for the invitation. I'm a lecturer in surgical data science at King's College London, and this is within the Department of Surgical and Interventional Engineering. And I've been doing research for a few years already, and it's fascinating how things are evolving, especially during the last few years, sorry. And I can tell you guys, I'm very fortunate to be involved in many multidisciplinary projects, with working with psychologists, other types of engineers, and especially surgeons, among all the flavors that you can imagine. And mostly recently, most of my research is related to urology, for radical prostatectomy, and neurosurgery. Those are the two main aspects of my research. But my background is entirely from the biomedical engineering field. And today I will be looking forward to discuss with all the members of the panel and with all the attendees of this exciting field. And last but least important is that we are very, very happy at King's to have a very state-of-the-art facilities, where we have Medtronic state-of-the-art equipment, where we have Proximie on board as well. So it's fascinating to see all these technologies coming together to solve real problems in relation to surgery. Thank you.
And I think that's a wonderful theme about actually how, and we'll probably touch on this later, how do we bring organizations that perhaps used to sit in silos, like the private and public sector, technology, how do we bring all those all that expertise and all that knowledge to have a real learning healthcare system, and work across sometimes quite high barriers. But without further ado, I'm now going to hand over to Prokar to talk through each person on the panel has a few slides, where he's going to tell you a little bit more about various hats that they wear in a little bit more detail. And I can see that there's a question that's come in around Dr. Nadine's work. So I will ask her in the background just to share her contact details. But if you wouldn't mind sharing your screen, Prokar, and over to you for the next few minutes.
Thank you very much, Rebecca. what an amazing panel. I mean, I'm excited that these are the folks who are going to deal with me when I become ill, as we all eventually will and end up in hospital. So thank you. I mean, I'm inspired by you guys. Let's kick off with Nadine, a colleague and a surgeon, because she is trying to solve a problem which really became pretty head-on during the pandemic. I remember there was an operation which one of my colleagues had to do robotically, which she hadn't done before, and the expert on Earth was 5,000 miles away in Seattle. So Nadine was the one who joined them up. Yes, the operation happened 10 o'clock in the morning at Guy's with the Da Vinci robot, but the guiding surgeon was sitting in his pajamas at 2 a.m., would you believe, in Seattle. And that made headline news, no wonder, in the Sunday Times. So Nadine, over to you. Proximie it is.
Thank you so much. Thank you. And you know, it's been great having the incredible scientific and clinical support that King's and Guy's and St. Thomas has provided. But to just give a very quick, I'll try and keep this as short as possible. And if anyone's interested, we can always pick it up offline. For me, when I spent, over 10 years working in global health, traveling to many parts of the world to look at sustainability and capacity building in surgical care. And also I worked for about 6 or 7 years with industry, helping them translate and bring new products to clinical pathways. It became clear to me that we have a real challenge where everything in the surgical operating room is really dependent on physical co-presence and is quite analog. And so everything is about a moment in time. You leave the operation and what you're left with is really just an operation note that someone scribbles at the end of the case. So this opacity, this lack of access to the operating room, to me became a real challenge and I think a hindrance to how we really scale expertise, but more importantly, make sure that patients are getting the best care the first time, every time. And, I have many stories and personal family stories where this unfortunately was not the case. And so I started to imagine a world where operating rooms all around the world in a very secure and compliant way could be connected, could be immersive and collaborative. I could be sitting in London and I could dial into a case in Vietnam, or a colleague in the US could dial to a case to the UK, or even in the same town, but rather than having to drive across town, just being able to dial in. And what that could do for training, for education, for quality improvement, and for standardization. And so we built this cloud-based software that is vendor neutral. So we work with any hardware and we're able to virtually do this. And we're now about 150 people in the team. We're deployed in over 500 locations around the world in over 60 countries, including very, very robust public sector groups like the UK military. And we've been able to really make an impact in over 20,000 cases so far. And our mission is really to deliver a connected surgical platform that will help deliver quality surgical care for all. Whether you're in a beautiful central London teaching hospital, as we're very fortunate to be in, or you're in a rural area, or even in a small camp hospital in the middle of nowhere, you should have access to that same quality care. You should have access to that expertise, and your patients should have access to that care as well. And we need to recognize that on the backdrop of the 21st century challenges, we have challenges around access, we have challenges around resource, and we have challenges around the workforce, which has only become ever more accentuated since the pandemic and the cost associated with it. But if we take a moment and look at what surgery looks like, I mean, this is how the evolution of surgery has evolved. It hasn't really changed very much. This is back in the 18th century. You had people sitting around kind of an amphitheater type environment, and you have the surgeon operating in the middle and everyone watching. And this was the genesis, the 3 C's: communication, collaboration, and co-presence. And it held us to good stead. It helped us evolve. We pushed each other. We questioned each other. We designed new methodologies in surgery. Fast forward to sort of this century and the last 100 years, we still do more of the same. We put lots of people in an operating room and hope that they're all going to learn and take the expertise to their own centers. But what you can see in this picture, and it is a bit facetious, there's a lot of people in the room, but it is a true OR. It's from DeBakey, who's a famous cardiologist in Texas. I'm sure Professor Dasgupta has had his operating room this busy as well, many times as well. But what you see is that this introduces a lot of variation, a lack of standardization, and each person is going to take an impression of what they learned and go back to their OR and deliver it probably in a variable way. But what the data here is unstructured, it's siloed from procedure to procedure. And what the future should really be is connected, collaborative, data-driven, transparent, and accessible to everyone. And that's really what we want to do. And the need is compelling. The desire and the use case is large. We have over 310 million procedures happening globally. We have 5 billion people around the world lacking access to safe surgery. We have 18 million people that die every year because of that lack of access to surgery. 1 million are dying because of complications that were avoidable in surgery. And there are, over 143 million extra surgical procedures needed worldwide, with a workforce that's only growing maybe 2 times. And so we can see there's a huge disconnect about how we do it. And so we aim to solve those challenges by leveraging technology and software to improve patient outcomes, improve access, and scale expertise. And I'll show you a video that shows Proximie in use.
And anything that we can do to improve accuracy, obviously, will improve the outcome of the patient. And that's really what we're focusing on by working to develop these platforms.
With Proximie, I've been using it really heavily since May. I was introduced to the technology during COVID. And it's just been a game changer. I am able to, every time I operate, have another surgeon in the room.
I think this technology works brilliantly. The fact that I can see you perfectly, I can hear you perfectly, and I'm literally in the middle of fracture clinic on an NHS Wi-Fi on my ordinary laptop.
Dr. Desai is a neurosurgeon, but he's our endovascular fellow. And he was able to handle this, using this technology. And that's why we think this is extremely important. So for a junior fellow to be able to handle a case like this just speaks to how we can really democratize good endovascular technique, expertise around the world and help patients around the world.
And through this technology, we're able to scale efficiencies as well. I mean, as we speak now, there are the largest number of robotic-assisted prostatectomies taking place at GSCT in one day, using this system and many of our surgeons within Professor's department. So to round up, what we're really trying to build is a system that enables telepresence, content management. You're able to use these videos after the case to learn, to share, to give feedback, to consume, and then to hopefully share data insights that will improve data outcomes over time. And we've published many papers that have demonstrated the benefits around this, around efficiency and cost. And we see the future really about a global connected network, an operating system or digital blueprint of where surgery should go and how we plug into systems and devices and, like Modar's company and others, where we can really help accelerate the acquisition and the delivery of surgical care around the world. So thank you very much. I'm sorry if I took too much time, and I'll hand back.
No, not at all. That was absolutely fascinating. Thank you. And I was really struck, obviously as a data scientist, the moment you put numbers up, I'm like, I get excited. But it's a really sad statistic, isn't it? That 65% of the world's population, you quoted 5 billion, do not have access to this kind of care. One of the things also that struck me as well, just before we move over to Oliver to introduce some of the great work he's doing, is that point. I remember a radiologist once saying to me, Rebecca, I'm the only profession that takes a picture of their mistakes. Insofar as someone can go back and audit, but also actually learn and look at a particular DICOM image, or to say, actually, was this the right case or not? What really struck me, as well as what you spoke about, kind of software as a service and democratizing that irrespective of GDP, by the sounds of it, is the ability actually for people to learn, given the workforce crisis that we are seeing globally, as you quite rightly touched upon it in the aftermath of the pandemic. So thank you very much. That was super insightful. So Oliver, over to you.
Thank you very much. So I'll be talking a little bit about kind of mind and body and prostate cancer, and particularly explain a lot why there is a problem and why it is an important problem. And then I'll talk briefly about how we can kind of try and improve that problem, how we integrate kind of digital healthcare within that, and what the future holds for these patients. So prostate cancer is a huge global problem. So we know it's the second most common male cancer in the world. So over 1.4 million new global cases. So huge numbers of patients affected. And and increasing amounts as well. So because of increasing testing everywhere and more people are picking this up incidentally, and the aging population globally as well, or particularly in developing countries, we are seeing more and more people being diagnosed with prostate cancer. And the most important thing about prostate cancer is that it's quite a slowly progressing disease. So unlike your pancreatic cancers, many people that are diagnosed will survive with their disease for a long time. So we know that at 10 years, 78% of people will still be around and have undergone treatment. But what that means is that they've also are around to have the implications of the disease and the treatment with them as well. So that means that they have a kind of a unique challenge afterwards as well. And increasingly we're realizing that long survival does not mean good quality of life. And arguably it becomes even more important with long survival because people are having to survive and are having to live with the consequences of treatment. And the challenge people face in prostate can be quite unique as well. So not only the undergoing the diagnosis, but also the treatments of prostate cancer. So we know that it can cause erectile dysfunction, urinary problems, and there's also profound kind of social implications. So access to kind of having problems of going back to work if they were working, or problems with the relationships with the partner because of things like erectile dysfunction can happen. So the impact on their well-being can be profound. And traditionally, particularly within the urology world, there's been a strong focus on that physical health. So people are very focused on how are they going to survive for 10 years, or are they going to have erectile dysfunction? But they're not really thinking beyond that. So a lot of the work we've been looking at is looking at that mental health and mental well-being impact. So we know that about 17% of people will have depression and anxiety at some point during prostate cancer. And even more remarkably, kind of one of our studies found that kind of 10% of people will have kind of recent suicidal ideation. So huge numbers of patients when you consider the global incidence of it. And even suicide mortality is known to be above the general population and even above other cancer populations. But mental well-being is more than just mental health. So it's more than just depression and anxiety. So we know these patients have other issues which are hugely important. So things like fear of cancer recurrence is called one of the most common unmet needs in cancer. About 40% of patients from one of our studies are affected with significant issues of constantly being scared if their cancer will come back or is going to progress. But also issues around their self-esteem, how they view their body, so body image, and also their masculinity. However people define masculinity, we know it's a significant issue in prostate cancer, having, for example, male organ removed, or the issues with erectile dysfunction, for example. And why is all of this really important? Not only just for quality of life, but we've actually shown that there's a huge relationship between mind and body. So mental health outcomes are hugely important for prostate cancer outcomes as well. So ignoring one would mean ignoring the other. We know that depression is linked to poorer sexual outcomes, for example. We know depression and anxiety are linked to poorer urinary function after treatment. And importantly, also, depression leads to poorer mortality outcomes. And that risk is seen in some studies up to 86% higher risk in some of these studies. So there is a huge relationship between one and the other. So whilst a lot of the work now is kind of identifying the problem, so how do we fix it basically? And how do we best do that, integrating kind of digital healthcare? And so I think where we're at now is trying to identify basically who are those who are going to be at risk and how we can target them to improve their outcomes later on. And there's a lot of work basically in integrating big data to improve this. So integrating national cancer registries or local mental health registries, for example, to try and identify those patients which are more likely to have problems, and using kind of AI-based modeling for things like that as well. And within treatment and prevention, there is a big move within mental health. So moving to try and improve accessibility of that treatment via online interventions, so online cognitive behavioral therapy, for example, because of the huge waiting lists and things which are associated with normal face-to-face interventions at the moment. And that's what we're trying to kind of evaluate to see how we can best treat and prevent those problems using these kind of digital healthcare. So thank you very much, and happy to take any questions later on.
Thank you, Oliver. And yeah, I would encourage the audience to think about those questions and let them percolate with their coffee throughout these presentations. But just before we move on, Oliver, I had a question, if that's okay, and I get the privilege of asking it because I'm moderating. But you spoke about, I mean, these are really difficult, I would imagine, conversations for anyone to have, to talk about erectile dysfunction, to talk about depression, to talk about anxiety in that kind of patient therapeutic relationship in clinic. Is that 17% that you said, you know, that's what the literature is telling you? Do you think that that could be an underreporting because it's specifically asked for, or and therefore, you know, you've kind of given a questionnaire, you know, maybe the BADS or the anxiety type questionnaire? And if you do think it's an underreporting, do you think that digital health technologies and actually accessing patients could be helped through digital technologies, where actually telling a machine or a piece of code, I'm not feeling great today, and actually I have sexual health problems, could actually help highlight more of the problem to you as a clinician?
Yeah, absolutely. I definitely think it is underreported, to be honest. And a lot of that is actually the access to healthcare. So the frequency which we will see these patients, for example. So unfortunately, in clinic, we may not be able to see them every couple of weeks, but actually once you do introduce kind of digital healthcare, so for remote monitoring, for example, of these things, I'm sure that you then would have higher incidences where you can ask these patients these questionnaires for every kind of 2 weeks or every month, as opposed to every 6 months or every year that we do see them. So I'm sure it is vastly underreported. And like you say, also sometimes having that face-to-face discussion, particularly there's a classic image of the prostate cancer patient being stoic older man and may not want to discuss these issues with someone face to face, but actually perhaps having that kind of anonymity might help as well.
Thank you. So I'd like to move on to our next presenter at Medtronics. So over to you, Modar, if that's okay. And if you wouldn't mind being in presenter mode, if you have any slides, that would be fab.
Yeah, of course. Thank you very much. I'll just share my screen for you guys now. And it's great actually to kind of listen to the other panelists, because there's a lot of synergy between what we're all talking about and what the main aim here is. And we've heard kind of like fantastic speeches from Nadine, for example, to say, like, look, we want to be able to democratize these types of technologies. We want to be able to reduce variability in surgery. And we're all looking to strive, as Oliver put it, for better outcomes. So whether that's better outcomes for erectile dysfunction, incontinence, these types of things, that's the aim, to make people's outcomes better. And how can we then support things like that? And the technology I'm here to speak about with you all is surgical robotics. And I'll give you some background into robotics and what it is, just because as soon as you mention robotics, a lot of people assume that the robot does the surgery and there's nobody present at the time. However, I'll share an image of the robot itself. So this is Medtronics surgical robotic platform. And you can see there's various different components. There's surgical arms that are by the patient that actually are docked to the patient with instruments going into the patient. But what you can see on the right-hand side is a console where you can sit at, and this is for the surgeon to sit, and all of the surgeon's movements on this console are translated by the arms into the patient. And what they allow the surgeon to do is to make very precise movements and have the ability of wristed articulation of the instruments, kind of the opposite of what you have with laparoscopic surgery, but very similar to what you'd have with open surgery. Now, the differences are, when you look at open surgery, you normally have these huge incisions, especially for kind of large cancer work. And what you have associated with them is then longer recovery times, longer stays in the hospital, infections, cosmesis issues, etc. And we moved away from open surgery for quite a large volume of procedures into minimally invasive surgery. So I think the term a lot of you be familiar with is keyhole surgery, which is laparoscopic surgery. And that's where you make small incisions in the abdomen or the pelvis or the thorax, and you insert instruments and do your procedure looking at a screen as opposed to directly in the patient. Robotics takes that one step further and gives you the ability to control very stable instruments on very stable arms, to have even more precise movements and 3D visualization, as opposed to looking at everything on a flat 2D screen. So that's a bit of background on robotics, and the ability for robotics to then give you these precise movements is what allows you to then have faster recovery times, less blood loss, less complications. And in addition to that, you go through the kind of training programs, which we want to be able to standardize, right? So you want that reduction in variability and a few other things, but I'll show you a quick clip here. So this is inside a patient, and the surgeon would be sat at the console on the right-hand side of the screen earlier. And you can see that they're able to make very precise movements. So the robot is able to scale these movements down from what the surgeon's actually doing. And it means that you have very precise surgeries. And this would all be in 3D. Now, robotic-assisted surgery is not a new thing. It's been out for quite a while, 20, 25 years now. But the issue is it's essentially limited by a few factors. So if we look at where minimally invasive surgery trumps over many aspects of open surgery, it's with the fewer complications, better cosmesis, shorter hospital stays. And the benefits that robotics gives is a 3D visualization, the wristed instruments, so you have the ability to work around and have these precise movements, but also the ergonomic advantages. So a lot of healthcare professionals will know if you have a laparoscopic or an open case and a difficult patient, you're sat at the bedside for 2, 3, sometimes 4 hours at a time, and not the most comfortable of positions. And if you need to do that day in, day out, sometimes several times a day, it takes its toll. So being able to be comfortable and relax while you're doing these procedures means that essentially you can give all your focus and attention, concentration to replicating these procedures and having that reduced variability. Now, when you look at robotics, only 2-3% of surgeries are done robotically. So there's a huge volume of procedures that are still able to be performed, and the benefits advocated for these patients with robotics. And when you look at the reason for that, it normally always comes back down to the cost. And this technology is very expensive. It takes into the hundreds of millions, if not billions, Medtronic has spent to develop the technology. But we want to be able to remove these barriers. We want to increase that equity of access, not only for the hospitals to acquire the systems, but also for patients that would maybe not have had robotic-assisted surgeries because of the cost implications, then to be able to afford these, be afforded these surgeries. So for Medtronic, what we've done is we've worked with several thousand surgeons over the last 8 to 10 years to develop this technology, and we're looking to break down these barriers. So we want to be able to assist the hospitals and surgeons with access to this technology, and then to be able to democratize this type of technology to increase these outcomes that are afforded to the patients. So the question is not if, robotic-assisted surgery is not a fantasy, it's here, it's with us, and it's seen as the future. So what will be possible with Hugo, which is our robot, in your hands? Thank you.
Thank you very much. And I feel like I should have made sure that everyone had had their breakfast just before we saw some of those wonderful captions. But it was absolutely intriguing to see the types of movements that could be made in that video. So thank you. And I just had a question from my side. From, you know, obviously I work at Roche. I understand that therapeutics and diagnostics, you know, have a long, slow regulatory pathway and are hugely costly, and you alluded to that. But you also suggested that you were thinking around, I don't know, potential new business models or reimbursement models to improve equity of access to this kind of technology. And I just wondered if you could touch a little bit more, either now or in later on, about some of those strategies, so that we you know, you are lowering those barriers. Is that something you can touch on now?
Yeah, of course. I can give you a brief background on it. I mean, firstly, competition is a beautiful thing. So when you have a market monopoly, it means that essentially prices can be dictated as opposed to set in competition. Medtronic, being the largest medtech provider in the world, we have the ability and the economies of scale to be able to drive the production of this technology and bring these costs down. In addition to that, Medtronic being involved in the minimally invasive space for the last 60, 70 years now, we have a lot of the technology already developed and already in use across virtually every single hospital in the world. So the integration between the technology we already have into the robotic platform is seamless, which allows us then to begin to chip away at those barriers and make sure that robotics is then accessible to those in the market that have not yet had it.
Brill, thank you so much for talking through that with us. And in no way last but least, over to Alejandro.
Thank you very much, Rebecca. I hope you can see my slides right now. Yeah.
Perfectly, yep.
Okay, brilliant. Okay, so again, my hat is in the surgical data science field. And if you are not aware of this field, pretty much it's a term recently in the last 3 years coined for that process of capturing data, curating it, analyzing it, and building AI models for surgery. And the way I see the field at the moment is surgery itself is an art and innovation, and we have seen substantial changes through many years. But in my opinion, this is changing dramatically in much more recently. But what I notice, and that's entirely my opinion, is that the current practice is mostly anecdotal. The teaching is one surgeon to another surgeon, and surgeons' expertise relies entirely on the clinical exposure to cases. Sadly, this can be random, and of course, those getting access to those complications and those difficult cases will learn the most, right? But at the same time, we've got plenty of opportunities of data that can be recorded and used strategically for improving this journey, right? And this is what I mention as becoming an evidence-based surgery, where we can rely on leverage on that data to improve practice. And in this way, the way I see the field is moving on to somewhere where we actually need more technology in the sort of a platform that will facilitate the translation of projects or research into medical device software products. And this is something that is actually lacking at the moment. It's becoming very, very difficult to prove that devices, especially relying on AI, can become a product that can be reliable, can be efficient. But the field, the way we see it as well is, strictly speaking, related to surgery, where we would like to investigate what are the actions surgeons do. And if we are able to quantify or understand those actions, we are very likely to start measuring the quality of those. And once that can be done, probably we will be in a better position to build causal models that would let us not only to correlate, but also trying to find what are the effects of those actions that surgeons do that could lead potentially to complications. And of course, if we know that, the idea will be to build assistive technology to decrease these ones. There's a lot of, in AI currently, there's a lot of hype in terms of not only using data, but also bringing many areas of scientific research, and especially in the sort of physics. And our bodies is purely physics, right? There are underlying functions that we hardly understand. And if we bring these two fields together, that will help us understanding those dynamics of soft tissue during surgery, right? And this is how I see the field. And what I would like to show you is just taking a glance of our current research in surgical data science that my group and I are doing. The first one is in collaboration with Professor Dasgupta, and this is in relation to robotic-assisted radical prostatectomy. For those that don't know, at some stage where men have advanced prostate cancer, that gland needs to be removed from the body before the cancer spreads to other parts of the body. And current practice literally is robotic assisted surgery to do this intervention, as you can see in the diagram in the center. But there's a lot of work that we are working in relation to this procedure. On the left-hand side, for instance, we are using AI in very different ways. The first one is, can we predict more efficiently the cancer grading of patients given histopathological images, as you can see at the top. But also we are looking into bringing and merging that information that is available in the sense of active surveillance. So the patient journey, they are getting diagnosed, they are getting treated, and this is happening at some iterations, right? And we would like to understand when treatment is more efficient. And also there are specific types of surgery, of cancer that are much more aggressive. In this case, one of them is called ductal cancer. And once this is the case, this is pretty much the most rapidly way to cancer to be spread. So we would like to identify this from data. And we are very lucky at King's College to have access to Cambridge One, which is the most powerful supercomputer in the UK, and that's been provided by NVIDIA. And we are doing research on this aspect. But at the same time, we are working closely in terms of surgery, bringing technology that in the form of 3D printing patient-specific models or 3D virtual models, as you can see on the right-hand side of the image. And we've been looking at using state-of-the-art 3D printing technologies, but also collaborating with other spin-offs, specifically inner-side labs, where we can use the surgical platform to show those 3D virtual models to surgeons. But we won't be able to achieve this in a very efficient way if that wouldn't be the case for recent work in relation to Modar labels. And that's a consortium of different universities, one mostly King's College London, where algorithms using AI have been used for the automated segmentation of relevant anatomy of the prostate. So we are in a position to actually do this as a matter of a click, identifying the anatomy very rapidly. But also these algorithms use active learning, which means that the more the radiologists click to correct those predictions, the more it is learning and adapting to that data set within a hospital. And the second example, it will be related to neurosurgery. So I'm very happy collaborating with mostly with surgeons at Denmark Hill and at UCL in different areas. And here to be able to predict brain shift, which is behavior of the brain when the skull and the dura is open on patients. And that's affecting all any pre-surgical aspects when they rely on preparative imaging. Right? And we are also interested in how tools interact with the brain tissue, especially in the interventional radiology, but also bringing those aspects of the dynamics of physics AI and the Internet of Things together to get those observations in real time. And with that, there are lots of things I would like to share with you, but let's move on to questions and answers, and I will be very happy to share more of those thoughts. Thank you very much.
Thank you so much, Alejandro. And I got really excited because particularly in neurosurgery, that was when I was doing postdocs in the very thing about, you know, what happens in brain shift and how do we take the images that we get pre-surgically into the lab. So kind of touching again on Nadine's software, you know, that she touched on, and actually show a surgeon actually what is happening in real time, but also then updating predictions of how do we ensure language and motor skills if you consider resecting this part of the brain. So I might have to take you offline and have a 3D coffee. Wonderful. So thank you so much to everyone for giving us their piecemeal presentations. I'm really keen to kind of open this up to folks that have very kindly joined us. So I think there are a few questions in the Q&A that I've already seen, but I don't know if we have any brave souls out there that would actually like to come off mute. You don't have to show yourselves unless you want to. I realise it's Saturday morning, so you may not be as dressed up as you'd like. But does anyone have any questions that they'd just like to put to the audience for folks that have dialed in? I'm going to give us a few minutes just to think about that. David.
Yes, can I come in? What a fantastic set of presentations. You know, it's really comforting to know that we have so much expertise and technology available to help us today. And it has a bit of a poignant note for me today, because this morning myself and my partner received a very sad voicemail from one of my oldest friends who's been taken into palliative care. She's got very advanced cancer, and she only heard a couple of days ago that there's no hope for her. So she decided herself that she didn't want any more clinical interventions, and so she's gone into a hospice for palliative end-of-life care. But the question I want to ask, because we've talked about interventions and particularly focused around surgery, but I have a question for the panelists, which is based around non-communicable diseases, lifestyle medicine, and preventative health care. And I've only recently joined the British Society of Lifestyle Medicine as a member, but I've been practicing lifestyle medicine for 9 years. I just wondered if the panelists had any views on the importance of actually preventing people to getting to the stage where they need surgery, and whether lifestyle medicine and the importance of diet, exercise, and the rest of these things are actually going to help to reduce some of the workload that creates this kind of inequity in treatment.
Should I take that? David, thank you so much for this very important question, and I'm sorry to hear about that voice message that you received. Very unfortunate. I was intrigued by the front cover of the Lancet. In fact, I posted it on Twitter. This is last month, and it struck a chord with many, and it speaks precisely about this, i.e. preventative medicine is the way forward if we are to get a handle on many things, including the cancers that we deal with. So, you know, strange coming from me as a surgeon, because you'd think I would say the way to deal with prostate cancer is to detect it early and surgically remove it. But actually, we need to think beyond that and adopt better lifestyles, exercise, and focus more for the men on men's health early. What about smart screening if they have a family history, for example? I mean, women are much better at this than men are. Can we actually go looking for it? Not in everyone, because nature is going to get the better of us at some point. But in some, where there is that family history, can we detect it early? And can we adopt lifestyle measures to reduce the risk of harm from cancer or otherwise? And I give you an example of what we do in real life. We not only run men's health symposia, a number of which have been done with Mary, and thank you, Mary, again, for championing the cause of many men. But even beyond that, say by the time a patient comes to me with prostate cancer, and I'm to operate on them, I actually send them away with a fitness program from my anesthetist, my specialist nurses, and I tell them this is like running a marathon. You wouldn't turn up to the London Marathon front line trying to run it without any training. So why would you want to have a major operation like robotic-assisted radical prostatectomy, which has just been shown by Modar, through small holes without preparation? I mean, your body is not going to take it. So we put them on a fitness regime, a dietary regime, just like you would do with prevention. moving the curve further to the left. Why would you even get to the point where you need surgery? And we do that in real life to make patients healthier and better prepared for their operation. And hopefully, by doing that, we will actually stop many of them becoming patients in the first place. So fantastic question, and I think a long way to go. I think it will take us at least 50 years, if not more, before we see the impact of what you're talking about, David.
Can I just add to that? One of the presentations that I saw at the BSLM conference last Saturday was talking about therapy, immunology therapy for patients who've got cancer. And he was showing research that indicates that the prospects of people having immunotherapy with cancer are dramatically improved if they have a proper diet whilst they're going through these exercises. So, I thank you very much for your answer. It was very insightful, and I'm glad you're in favour of preventative of healthcare, because I think it will help everyone.
Thank you, David, for that question, also for sharing that really difficult news. For those of you that know me personally and professionally, you know that I like to be quite inflammatory. I think it's quite a good thing because it pushes the boundaries of thinking, but it also allows new thinking to percolate, I found in my experience. And I was quite struck the other day, for various reasons, when Liz Truss was giving her speech. And one of the things that she was saying was, well, I don't care if you buy 2 chocolates for 1. And that's the person leading our government and governing our country. I'm not making a judgment on that, just to be clear, so that I don't get fired. But more importantly, to that point, what role does government play here in thinking about the conversation with the public around a healthy lifestyle, and actually maybe taxing sugar and sweet things, or is something that they maybe should be doing for a delayed discounting for people's health? And how much do we feel that the public would be open to that, especially given the cost of living crisis, where actually some people can only afford to go to McDonald's? So I just wanted to kind of open the floodgates a little bit away from technology, because all these things are when someone is in hospital. But if we're thinking about kind of preventative care, I think that we do need to touch on politics. My folks always said to me, never bring up religion or politics at the dinner table. And it's the thing I always do. Which explains a lot about my family dynamics. But I just wanted to open that up to you. What role does governments play here in preventative healthcare?
No one is saying anything, so I think a very controversial question. The short answer is a very important role, and I give a positive thought on this. What has happened in bladder cancer, where the major driver is smoking, and the government has in the UK over a number of years banned it in public places. And I can guarantee that in 50 years, the incidence of bladder cancer is going to drop. It will take time, because these things that are lifestyle dependent take time to manifest themselves, and therefore the benefits take time to show themselves. But again, that's a positive thing in bladder cancer that the government has done in the United Kingdom.
Extremely well balanced from my side, so thank you for that. Right, so I'm going to pass over to Nadine, if that's okay, because your presentation is generating lots of discussion, which is wonderful, about higher and lower income countries. And I just wondered if you could touch on what you're doing in other countries, and have a look at some of those questions, and invite you to comment on that, if that's okay.
No, sure. And thanks to the participants who are putting in those questions. I've tried to answer some of them in type form, but I'd love to speak about it as well. I mean, one of the things that was always very clear to me, and the idea of Proximie started back in 2013, 2014, was really around this idea of democratization and access. And this idea that we can't have this sort of global north, global south sort of situation. There has to be an ability for every patient, no matter where they are, to have access to that best clinical care. And a lot of that kind of the fundamentals of that sort of belief and really kind of fed itself into the product development of Proximie. So from day one, the platform needed to work on mobile app and browser-based, so you could access it with any device. From day one, the platform had to be able to work on very low bandwidth, because in certain parts, and I mean, even in the UK, in certain hospitals, you don't have really great connectivity. I know in our hospital, it can be a bit hit and miss in some parts of in some corridors, but in those certain environments where you want to be able to even just hotspot of a phone, that has to be possible. It has to be low cost, so cloud-based software first. Those are things that make it accessible. And it has to be simple and easy to use as well, because you want to transcend the language barrier, where simply through icons and certain clicks, it's very intuitive, it's very easy to follow. And so a lot of what we did was we had to basically build the whole infrastructure down to the bare metal, so that we could really own and lean into that kind of accessibility piece. We had to be able to work on multiple cloud systems, so Azure and AWS. We had to be accessible in every part of the world, and we had to be compliant in every part of the world. So those were the fundamentals. And because we did that work very early on and built it for global purpose, we were able to then lean into real challenges and, really solve problems. And I think just one watch out for any digital technologies, it really has to be solving a problem. It can't just be a solution looking for some sort of exciting tech sort of flair or hype. It has to be actually trying to address a challenge. And so from day one with Proximie, whilst we're used in many Western countries, we're also used in many countries in the global South. We're used in Kenya, in Ethiopia. We're used in parts of Western Africa as well. In Benin, we were able to support, managing ear disease in Ethiopia and upskilling not doctors, but actually healthcare workers and other allied healthcare professionals to deliver good ear care and ear support. We've been able to support midwives and clinicians in Kenya in the delivery of safe obstetric care, which is a huge challenge there. I think, every few minutes a woman is dying because of that lack of access. We were able to support supporting the care for men with kidney stones in Benin, and we were able to dial in clinicians from the UK and the US to support them. And those are just a few examples within the Global South arena. But at the same time, as Prokar mentioned, and as I talked about, that same technology, we're not having to create a less, fancy version or sort of a more low fidelity version. It's the same software being used everywhere in the world. It's supporting, training at Guy's and St. Thomas's. It's supporting the launch of new robotic devices like Medtronic. I know we supported them in their first case in India a couple of weeks ago. So that ability to really democratize one software, I think, is really important. And it comes from the genesis of how you build your software from the get-go.
Brilliant, thank you. Just wondering, I've done a poor moderation session here because someone very kindly did have their hand up, was very patient, and now sadly has left us. So I think that's a data signal to me that I need to step up in watching people put their hands up. But I did want to invite the audience to ask any question that they wish. So I just wondered if anyone wouldn't mind popping their hand up if you have a question. No question's a silly one, to ask the panel today. I'm just going to keep my eyes peeled whilst we do that. And just on the Medtronic piece that you were speaking about, Nadine, can you just give us kind of, when you said you supported that, what that looked like? Because I think this is a wonderful partnership that you potentially have with Medtronic, but it'd be interesting to know more details just while we wait for maybe some folks to pop their hands up.
I mean, it's something we do across.
Oh, you're on mute.
Am I? Oh yeah, can you hear me?
Yeah, perfect.
Yeah, it's something that we do really across surgery with our medical device industry partners, where when they're launching new products, the key, one of the most important parts of a good launch is, of course, good training and good proctoring, good support. I know many surgeons do that as part of their career as well. They travel to different parts of the world to support new doctors and new clinical teams adopting new technologies. But you don't need to travel there. You can actually be doing this remotely. And so being able to sit in London and dial into a case in other parts of the UK or in India and other places can really help in that early learning curve. I mean, I used to run courses for these device companies, and everyone would come into a like a cadaver center, we'd all do the training, it would be great. And you might get support in your first case in person, maybe the second case. But there is a learning curve. And often you actually feel like you need that coaching and that mentoring and the support for maybe 5, 10, or 15 cases. And when it's not there and you have 1 or 2 things not go right, you tend to not feel confident to use those devices anymore. And sadly, then you sort of drop off the usage of these new opportunities for patient care. And so what we've really tried to do is really support our medical device industry partners in providing more distributed and longer term mentoring and coaching virtually, teleproctoring, telementoring. And what we've been able to do with the help of Professor Dasgupta and some of his researchers is actually publish papers that have demonstrated that we're able to accelerate training velocity, we're able to accelerate the learning curve, and we're able to do this in a really cost-effective way. And so what we do is we really see ourselves as a facilitator and an enabler to these great companies that are building incredible devices that are changing and reshaping how we're able to deliver care for patients all around the world.
Thank you. And we do have a question that came up in the chat, which was to all of you, and I don't know who would like to take this first, but was around, and I quite like the term tech equity. So you were very clear there that, you know, you do need Wi-Fi, you do need connectivity, you do need the hardware and software to run some of these digital health solutions. But what are your views around if that is going to widen health inequality, paradoxically, despite trying to improve access? So I think that's to everybody, actually. And I don't know who would like to take that, or if the question is very clear. I think the ask is, what happens when you don't have these things? Are you left behind? So I don't know who would like to discuss that first.
I mean, I'm happy to have a go, and then if anyone else wants to. So I think it's a really important point around that sort of tech equity and inclusion and digital inclusion as well. And what's really important as well is to recognize that whilst there are a huge amount of inequalities in the world beyond just the technology and digital inclusion. It's around, cost of living, access to food, water, and many, many other things. But ironically, the one thing that you see most prevalent in the world is that most people will actually have a mobile smartphone or sort of a device. It's one of those things where you've even seen just phenomenal work out of the global South, actually leapfrogging and showing the Western world how you can actually deliver services through digital, like the story of M-Pesa. I mean, many people would know that story, the story of sort of financial digital inclusion and others where, you couldn't get a bank account, but hey, we're going to start using our mobile device and our text messaging to do that. And there are numbers of other stories that I'm aware of, looking at the big EHR systems, right? You see your Epics and your Cerners. I mean, most countries in Africa are not going to be able to afford those kinds of systems, or around the world, quite frankly. And so there's a great companies coming out of Nigeria and other places that are actually building these solutions for their local economies. So they're looking at that digital inclusion, but making it more accessible and more affordable. And so we have to lean into the fact that, there is a high prevalence of sort of mobile devices. People do have them, these smartphones. So how do we build solutions and technologies that can empower them or sort of bridge that digital divide or that gap between the haves and the have-nots, but equally bridge the healthcare divide that we have, which is even bigger? How do we leverage these solutions that are existing to help democratize access to care, democratize access to expertise, preventative solutions, remote monitoring, virtual wards, all these incredible technologies that can take advantage of that kind of global footprint of mobile device acquisition. I think the more you start to introduce complexities of hardware devices and others, then it can become more limiting. But to the point that Modar made as well, I think the commoditization of these solutions now, I think, is helping and will continue to help over time as well. So I don't know, just some thoughts, but happy to be challenged on them, or if anyone else wants to add anything.
So we also have not just in terms of Western world or North or South, we also, for prostate cancer, have a common issue of, for example, and having accessibility of being able to use a lot of the things. So commonly in prostate cancer, disease of the more elderly, and for example, some of the studies we do, patients kind of in the 80s, 90s are not happy using a lot of these healthcare technologies. I think it's important for us to also develop things concurrently and make sure that there are kind of safety or equivalent things available at the same time for people who can't access it even within London, for example. We quite commonly see that.
I'll just add one other thing. I think there's a role to play in the various sectors that actually intersect here. So one of the things that we've done at Proximie, for example, is to partner with telco providers and connectivity providers, because, you know, as one organization, we can't solve all the challenges, but if we can bring all the kind of a coalition of the willing around the table to say, okay, we can solve the software piece, but we need the connectivity piece solved. Okay, let's go talk to Safaricom, or let's go talk to Vodafone, or let's go talk to one of these groups. How can they help us bridge that gap? And then let's go talk to the camera providers or the laptop providers or the hard, how can you help us, or the mobile providers? So bringing that coalition together to try and solve these challenges, I think is so much stronger than each person trying to address it on their own, because it's very complex and it's a big, big challenge that we can all play a small part in.
Yeah, and I think we definitely saw that, didn't we? Sorry, Alejandro, during the pandemic, of how quickly organizations that don't tend to be kind of bedfellows can just suddenly come together and go, right, we have a problem to solve together. I'm Microsoft Azure, you're a healthcare provider, you know, how do we work together, for example, to tell you in real time, unfortunately, how many patients are in ICU when there is no one HR system across the NHS. So I think I'm hoping one of the things I personally, professionally, I hope we don't see is a slowing down of that. I think that actually we need to build on the momentum of galvanizing and magnetizing partners that may not necessarily think that they fit together. Alejandro, I saw you came off mute. Over to you.
Yes, Rebecca, thank you. And I really thank the participant who asked this question about equity. I can answer that from the research point of view. It's becoming slow, but there's already few signs whereby we have nowadays publicly available repositories in the form of data sets that the community can use. And in addition to algorithms that are also publicly available. So these days, what is the expectation is to have that data publicly available. So that means that anyone in the world can reproduce it, anyone in the world can just run it. Of course, there are limitations in terms of hardware, or how would you train it. But at least from the AI point of view, at least those expectations can help in minimizing this huge gap that we can see in technology. Right? And I'm really happy that this is happening, but we are very far from what is ideal. So in relation to surgery, for instance, with these days we have data sets probably around 100 cases the most, right? So we need much more, and this is only related to probably one institution or two at most, right? So whether this is part of the Western world or whether that's somewhere else, I think there's a lot of work. Everyone can work together to make this happen. Yeah, and that's my view on that. Thank you.
Thank you very much. And I think as a data scientist, it's a real frustration, isn't it, around, or I feel that there's such promise, but actually there are a number of some understandable and some not so understandable regulatory barriers, you know, given that we all have our mobile phones, why can't we just say, yes, I'm happy to be a data donor, please use my anonymized information to train certain algorithms, and move that through the land of the software development lifecycle. The world is full of proof of concepts. Very few algorithms move it through to clinical deployment, and actually that's the yardstick at which I'm going to be judging my career. So I definitely feel your pain, and I think that, yeah, we're seeing and I think what's going to be really interesting in this space is given Brexit, we aren't part of the EU regulations, and actually the EU are doing a lot in how AI models can move through that software development lifecycle, and actually we are literally a bit of an island at sea with that. But the wonderful Mary has her hand up. Maybe she's giving me a high five, maybe she's got a hand up, I'm not sure, but I will hey you, I will hand over to Mary.
Yeah, thank you very much. This has been really exciting, educative, and an eye-opener. I just want to make a little bit of contribution on data. At King's, we've been involved in the 100 kilo genomics in blockchain, and I was part of that before the pandemic. I hope we're able to pick it up again. Now, there's an ethical dilemma. So these people come in, we operate on them, we use their specimen to collate data as to why cancer is more prevalent and the rest of that. So what do we do with the data? What if they come back in 5 years' time, 6 years' time, even after we've had a breakthrough, which is, you know, our initial aim of doing this? How much consent is enough for them to say, oh yes, I understand everything, even what's going to happen in 20 years. So I think that's one of the challenges and one of the areas where we need to do more work so that there'll be sustenance in what we're doing now to what we want to achieve in the future.
Yeah, it's a great point, and we don't sadly have a legal person on the call. However, I think it's and you mentioned blockchain around you know, the vehicles in which you can give consent in, because your intended use may change, and that's the issue we always have of going, we're collecting this data on behalf of doing this thing, and therefore you consent for it to be used for that thing, but that doesn't enable the ability to then necessarily say we're going to look at it for something else. And I think we see that a lot in life sciences and in pharma, and how there are vehicles out there, one of which you mentioned. I'm not advocating any types of technology, but how do we give the citizen, maybe again to Nadine's point, through a mobile phone, the ability to say, yes, I did that 5 years ago, and now I do consent to a new use case that my data could contribute to. And I think that yeah, I don't know if we have anybody on the line that would like to contribute to this, but I think it's definitely a legal area that we need to be very open and honest about, that we haven't quite cracked yet. David, hello.
Can I comment on there? Because I'm a great fan of wearables, and it's where I started with lifestyle medicine 9 years ago, and I got myself a smartwatch called the Jawbone Up that measured my physical activity and my sleep, and within 3 months I'd lost 21 kilos. And so I've seen how these devices have matured over the year to the point where now, if I don't know whether you can see it, I'm holding up one of I have two smartwatches. One is a Fitbit Sense, and this one is from China. And it measures my blood pressure, SpO2, sleep, a whole range of vital signs which are normally the domain of the medical profession. Now, this device doesn't have is not classified as a medical device. And I think one of the challenges that we had is the fact that when you're talking about wearables, there's two things. One is there is I wouldn't call it an obsession, but there's clearly concerns about the accuracy, clinical accuracy of devices like this. But the reality is that they are getting more and more clinical grade, and so they are able to capture data. And what's important, as I see it anyway, is the change in the people's vital signs over a period of time. And that's where I think devices like this, which cost $40, I mean, $40 to do all of this linked to your smartphone, I think they have enormous potential in preventative healthcare. But it does come back to this point of yours, is how that data is going to be used. I think in some cases it can be an unnecessary barrier to innovation. These devices have got quite a powerful contribution to make in preventative healthcare, but we need to find ways of legal pathways or supporting mechanisms so that it's available to everyone. And at the very least, if someone has a device like this and is collecting data, when that person goes to see a clinician or a hospital, they've got all of that data available to them. So it's not like going to someone cold. You have a history, and that data that's collected and the history of it is valuable in the diagnosis as well as prevention.
No, and I think yeah, so that's an area that kind of I'm leading on at Roche, actually. You know, how do we bring real world data, to your point, things that we're used to that have a low cost base? How do we pick out those temporal pertinent information of stitching all of that digital information to actually make a patchwork quilt about you, but then actually not create more work for a clinician? And that's the pressure, right? Because the pressure is going, is this kind of point about interoperability. Clinicians have very clearly told us, allied health professionals have very clearly told us, I don't want to log into a new thing. I just want it in my Cerner or in my EMR. And actually, how do you, I think the real challenge is not necessarily getting the data points necessarily. I think there are clear vehicles to do that, where you can say, I allow X to access my information, my anonymous information. But then I think the real challenge we have is, how do we get it into the clinic? How do we actually make sure that that data signal is interoperable with proprietary software and packaged in a way that a clinician, it's consumable immediately, to say, do you know what, given, David, that your normal base rate of, I don't know, I'm not a clinician, but your normal BP is this, actually something is changing significantly for you. And I think when we can, as a community, nail that about how we get data, pertinent information literally into the fingertips or into the mobile phone of your clinician, so that it's consumable for them, just like an algorithmic stethoscope. That's essentially what we want to do. We want to take data, give it to a clinician so that they can work in partnership with the patient to act on it. And I think that's going to be the real nut moving forwards that we need to crack as well. And yeah, I'm super passionate about doing that with folks on the call and with other people. But I'm just very aware of the time. One, because I have a dog walk planned and it's beautiful down here in Kent. It's a lovely and sunny autumnal day, and we're going to go for a walk with the dogs and a coffee, which will be lovely. But yeah, I can just see, so for example, Dudley has very kindly said, you know, I agree that technology has proven to read and update healthcare information, for example, with type 1 diabetes. Yeah, completely empathize with that. And I am cared for by King's College Hospital. They can take all my, every 5 minutes, my CGM and my continuous glucose monitor, reads to my pump, that is sent securely to the cloud, and my clinician and I can then converse every 3 months. Or I can then say to them, do you know what, I went on the Peloton the other day. Yeah, I'm that person that has a Peloton, how annoying am I? All my friends say that. But actually, you know what, my blood sugars took a complete dive. How do we adapt that so that I can still exercise, but you also have the data, and we can do like A/B testing. So that's really exciting. But I think it's these non-communicable, I can't say it, basically, these long-term health conditions and how we use technology in those areas. Now, Mary, I'm going to hand back to you, because you have brought together, hopefully, I'm obviously biased, but a fab field of people to speak. Hopefully folks have found it an interesting discussion on their Saturday morning, wherever they are in the world. But I know that you're doing wonderful things in this space, and I just wanted to hand over to you to close, but also on behalf of the panel, just to thank you again for all the wonderful and inspiring work that you do in this space. You're a true inspiration to me, and yeah, so if you wouldn't mind taking us to a close, that would be wonderful.
Yeah, thank you very much. Before I close, let me hand over to Professor Dasgupta. Do you have any last comments, contributions, or, you know, for us?
Thank you, Mary. Thank you, Rebecca. Thank you, David, and the wonderful panelists, Nadine, Modar, Alejandro, and Oliver. What I wanted to say as a robotic surgeon, having been a clinician scientist for 25 years, is this: be excited about technology, but equally be excited about the evaluation. As those questions flew in from Africa, I was convinced, as I have always been, that just because tech can do something and it looks smashing doesn't necessarily mean that it is better than standard of care. I yesterday tweeted about a paper that we have written amongst young academic European urologists, where we have done these exquisite 3D models of kidneys, whereby they actually help with the operation. But in the end, when we look at the outcomes for patients, the operation is easier for the surgeon, but the outcome for the patient is exactly the same as standard of care. So we have a long way to go, and we have to look at the cost effectiveness along with the clinical effectiveness. So I think be excited. This is very exciting, but also please, let's continue with scientific evaluation and not just throw the old away because there is something new. So that's all I had to say, Mary. Let's be scientific and let's continue in this most exciting field of technology and what it has to offer the next generation of patients. Thank you.
Thank you very much, Prof. Yeah, I hear what you say about throwing the old, because I remember when we first started minimally invasive surgery, years ago, we were also excited, and they started discarding some of the equipment, and I said, no, although I'm the lead for MIS, please, let's keep some of this. A, at that time, we didn't have many surgeons on board. B, we still have a high rate of conversion. So anyway, they moved away some of the things, and sometimes we'll be in the middle of procedure, and it's like, can I have? So I put together how many times I have this, can I have? And I went to management and I said, please, can I now get somewhere to store these things so that when we do need them, we can have them? I said, okay, we know that was coming. So yeah, I can greatly relate with that. The other thing I want to say is that I'm very happy to hear about the collaboration, because what Zenith Global between Neuro, I know Prof. Hachach-Haram, by the way, and between Kings and the other partners, because one of the mission at Zenith Global Health is to foster, encourage collaboration, shared learning, so that globally we can be at the same level, giving the best to our patients. And I'm so happy to have you amazing people, beside me. I wouldn't say behind me, because we all, work alongside me to make things happen. And I hope that we can continue to work together to do this. Not only here, even as we venture into LMIC, which we do at Zenith, we've been invited to Africa. We've gone to Nigeria, to Zambia. We've been invited to Angola, South Africa, and the rest of it, both for summit, upskilling, training. So I'll be troubling you, PS, just that you know. And I think Prof gave me the permission to trouble all of you. So Alejandro, Rebecca, of course, my darling Rebecca. Thank you so much. From day one, it's like, yeah, that's my girl and that's my girl. Thank you so much. David, you've been amazing. You've been supporting us technically since, it's over 4 years now, and you do it relentlessly. Even when we're in Africa, you make sure that the whole world see what we're doing. So thank you very much. Oliver, thank you. I think we had some communication. We continued that. Mega thanks to Nadine. I've sent her a private message. And so please stay with us, like I said, so that we can do this together. And when we do finalize the physical event, we'll be contacting you as well. Now to our audience, giving up your time on a Saturday morning, we thank you, we appreciate you. We hope that what you've learned here, you can make use of it clinically and in your private life as well to all around us, because this is how we can create ripple effect to reach as many people as possible. And do watch out for other events and seminar, webinar that we'll be doing with these amazing panels and the rest on social media, Zenith Global Health. And also this evening, some of you are joining us this evening. So we look forward to seeing you. Because of the train strike, we promised to start early. So if you find yourself, getting there early, don't worry, we'll be there. We get things going. We have drinks reception before the award ceremony. So thank you so much once again, everyone. And I wish you a pleasant Saturday and weekend from all of us at Zenith Global Health. Thank you. Thank you. Oh, wow.